Okay, hello and welcome everyone. Thank you for joining me. My name is Joe Chikvashvili, as you can see, and the webinar that we're going to I'm going to present to you is called Secrets to Improving Endodontic Access. Hopefully this will be very helpful for you. It's a topic that is very hot in endodontics today, and it's almost a new mantra that we have with access today versus what was taught in dental schools and even what's being taught now. So I thank you all. We have people literally from all across the world, in Africa and Europe. It's unbelievable when I was looking at the list of people that have registered and who are joining us today. So thank you all. Good morning, good evening, good afternoon to all of you. And hopefully you'll find this very worthwhile. Presentation will be roughly 40 to 50 minutes, somewhere in that vicinity. And when I'm finished, we'll have a question and answer, so please feel free to ask me anything you like. I will try to do my best to get through as many questions as possible. All right, like I said, my name is Joe Chikvashvili. Call me Dr. Chick for short. I'm Director of Endodontics at Newark Beth Israel Medical Center, which is a GPR, where we have 12 residents, and I'm also Vice President of the New Jersey Association of Endodontics, which is a large component of District 2, which is the endodontists in New York, New Jersey, Rhode Island, and Connecticut. I'm the Vice President of that organization, going to be President in March, and it's about 200 endodontists that we have roughly in New Jersey. And I'm going to be speaking to you guys actually from West Orange, New Jersey, which is about 10 miles west of New York. All right, so let's begin, and again, we'll have questions at the end. The goals for this lecture, as you can see, are the following. One interesting thing about access is before you can, it's a little bit ironic, before you can do great access, you actually have to be able to learn how to clean and shape and locate canals. So access is the first thing that we do, but really it's the last thing that we perfect. So those things hopefully you can get with experience, but I'm going to give you some ways to learn how to make that access become smaller but also better. And that includes reading radiographs better, evaluating anatomy, which is something that you have to just really know. Hopefully, by the way, you can hear me. I have somebody saying that the audio is a little low, but if it is, let me know. Also, preserving tooth structure and locating missed canals and CBCT, which I've used in my office for 8 or 9 years already. I was one of the earlier adopters of that technology, okay? But the most important is also judging complexity, because as much as I'm going to teach you all how to do better access, remember that at the end of the day, there are some things that are better left to an endodontist or to someone else, okay? So just like if I'm going to show you this beautiful picture by Vincent van Gogh, you're not going to automatically be Van Gogh tomorrow and be able to do this. It's going to take some practice, some learning. And one of the things you have to realize is it's a slow process, but there are many different steps. You have to really look at, like in this picture, you have the background, the foreground. You have to look at size, what looks smaller, what's bigger, and kind of visualize what the end product is before you even get started. We do the same thing when looking at a tooth. So here's a tooth I just want you to focus on this one tooth. And what you can see, hopefully you can see my cursor here, is this is going to be a very bad bend. Okay, everybody sees this. But this is also a bad bend. Most people think, oh, this is terrible. Well, the worst bend, just so you know, is always a coronal bend, because the most flexible part of the file is the apical, the tip. So if you have a sharp bend at the end, it's usually not as bad as if you have a high bend, coronal or mid-root. And this mid-root bend is very bad. So even though this is a horrible bend, usually this would actually be the worst bend, the distal. Now, interestingly, when I put the files in there, you see that they're both terrible bends. And this is, I guess, what life is when you're an endodontist, at least where I am in New Jersey. You have a terrible bend on the distal, and on the mesial, you can see that aside from the regular curve, there's also an S bend. We call it S because the file bends this way, and then it reverts and bends the other way. This is an incredibly highly difficult tooth to treat, okay? But the point is, before you even get to this, you should look at this tooth and say, you know what, this is something that, maybe I don't want to tackle, all right? And yeah, at the end of the day, we got a beautiful result with 4 canals, 2 here in the mesial, a lateral here. There's actually a lateral here that you can see better on another radiograph that I didn't include. But end of the day, you have to be able to see this complexity because you're going to get in trouble. And once you start, it's often difficult to then go back and fix something. Okay, so how do we do this? How do we avoid these pitfalls? It all starts with having great radiographs, and that means you have to have a really great PA and bite wing and an off-angle PA, and you have to be able to really already know what you're looking for in anatomy. Okay? We're going to go through all these, and I'm going to show you how to look for the complexity and also be able to manipulate the image if you have digital radiography. Okay. A good PA, this is also, beauty is in the eye of the beholder. This was a case where somebody said, you know what, I think there might be a shadow on number 7, and there's something going on number 8. And yeah, this is a good PA of number 7, but it's really not a great PA. It's a great PA of number 6. So this is a better PA of number 7, and now number 7 doesn't look like necessarily it has something going on like it does on this one. But it looks like there's something going on number 8. So what do? You say, look, I'm sorry, but we haven't gotten the picture that I need to see to the patient. And you try to take better PAs. And eventually, on the 4th PA, and this was not, again, I didn't take it, but the dentist took it, but it's a great, great case to show you guys. You could see that the radiolucency that we've been looking at all along is really this thing right here in the middle. And this is a classic example of an incisive canal cyst. Okay, so you say, well, is that common? I don't see that very often. It's actually the most common odontogenic cyst. You might not see it a lot. It's probably missed a lot. But the problem is sometimes if you don't take better radiographs and you don't pulp test the teeth properly, you might end up doing some root canals on teeth that don't need root canal treatment. So this is why you need to have great radiographs. Great radiographs also are just for routine things. Like in this case, patient had pain to hot and cold, and they were curious, what tooth is hurting you? Well, when I ask the residents this, some of them say, well, it's got to be number 4. It has such a deep composite. It's to the nerve. Some say number 3. It has a crown. Some say number 2. Here's the thing. This is a okay PA, not great. This is a great PA. I got all of number 2, all of number 3, all of number 4, and it's still difficult to tell. Now watch this. Not so difficult to see what's going on. You see what a difference a bite wing makes? So there are people that they don't take bite wing radiographs routinely. I will almost always do that. Now, there's some minor exceptions. Maybe it's pretty obvious there's great bone, there's no question, it's this tooth. But in general, it is very helpful to take a bite wing. And the way I read a bite wing is very different than the way most people do. I don't just say, okay, it's obvious he has decay here. I look at it like this. You can see that this is a flat occlusion, so the person is likely in group function. They might be a grinder. Obviously, there's gross decay here. There's some decay here. There's a pulp stone here. There's a very deep restoration here. You can see the canal is somewhat calcified, definitely here and here. There's class 5 lesions. There are 2 materials here. So this person's maybe had some patchwork dentistry. There's a post here that's really useless because if you go to put a post in a tooth, you should have it going much further down than this because this is really an ideal way to break a tooth because of the way the fulcrum is. So you get all this, and you see also periodontal bone loss here. You get all this information just from one bite wing. So please make sure you think about the possibilities of taking a bite wing as often as possible, especially when there's a lot of dentistry or a lot going on. Okay, and not just a bite wing, but an off-angle, or I say bad PA because you'll see in a moment. This is a good PA of a patient that came to me actually only 2-3 weeks ago and said, you know what, my implant's a little loose. And I looked at it and I said, yeah, the gum looks red, the implant's loose, but this looks great. So then you take another PA and look at this. This was kind of a bad PA or bad bite wing, and you can see that the implant is actually fractured right here. Now, you don't see that on the previous PA, which was a great PA. This is a good PA. This is not a good PA, but this is a better PA or bite wing, whatever you want to call it, for showing what the problem is. Okay? So don't be afraid sometimes to tell your assistant, say, look, you got a great PA here, but let's try and take one more like a bite wing and see if we can see what's really going on coronally, because I already see everything apically on that other one. Okay? So Again, we mentioned you have anatomy and have to realize that some premolars have one canal. They can have two canals or three canals. And same thing with molars. You can have literally one, two. This was a very difficult tooth. I'll never forget. This was the last tooth I treated in 2010. And then you have three canals like here. And just for most of you, I don't know if you know, but this is, we call a type 2 canal configuration. Wine classification type 2, when you have two into one. The significance of this is, in my opinion, this is the second hardest thing to treat endodontically, because if you're using rotary instrumentation, you have to really do one canal to length, and the other one you should not take rotary to length. Otherwise, you take a risk of breaking a file, okay? And here you can see how complex the anatomy is. There's actually two furcal canals in this tooth. Again, you can have four canals, and they can go in every which direction, like the tooth on the left. And you can have four canals like the tooth on the right with a lateral on every single canal. Lateral here is from the distal, lateral here from the palatal, and this goes all the way to here. It's all emanating from the mesial. Okay? Only time I can think of that I had a tooth that actually had a lateral on every single root. But that just shows you how complex anatomy can be. And five canals. I have approximately 40 teeth now, 30 to 40 teeth, definitely 30, in the last, I would say, 4 years or less with five canals. And this is one that I'm going to show you actually a couple times today because it's interesting for a number of reasons. So you can see it has two mesial canals, three, and in reality it has three portals of exit, but it still has five canals. And I can tell you I've had a few people where until I found that fifth canal, two people, and until I cleaned it well, they still had discomfort. So it's important because what often happens is this person gets four canals, patient still has discomfort, you think, no, they must be crazy, there's no way, I did a great job, and the person might end up losing their tooth because the endo wasn't performed as well as it could have been. So here we go with the tooth. This looks, you know, relatively routine, a little bit of tartar here, calculus, but everything looks okay. You do the root canal, you say, okay, that looks uneventful. Well, if we go back 2 slides, this is the same exact tooth. So here's your tooth, and you can see that funky one next to it, and it's got 5 canals. You don't always know that a tooth has 5 canals by just looking at it. This looks like a regular. Now, a few things will tip you off. One is that you see the way this ends right here, this canal? It looks like it's short. 70% of the time, a distal canal on a lower molar will actually, the distal root, the canal will end and exit towards the distal. So it doesn't end here usually, like it does on the mesial. It actually usually curves towards the distal. So number one, this is probably correct. But number two, I want you to realize that the access here is not perfect because I had to make it a little bigger to treat all 5 canals. And that's okay. We have great restorative materials today. You know, it's 2016. And, you know, we really should be able to do, you know, great restorative work. So ideally, you want to make tiny enough accesses where you preserve tooth structure, but sometimes that's not always plausible. But one thing you should see is the way this tooth is long and has an S-bend. That should tell you if this is very complex, and it is, this will be definitely at least 8 or 9 out of 10 complexity. The likelihood is this is not going to be a normal molar either, okay? So that's a hint for you. Looking at more complexity, this is a tooth that another endodontist did, and eventually the tooth was going to be extracted because it was broken and there was a large cyst here that an oral surgeon biopsied, and it came back radicular cyst. But he wanted me to take a look because he said, I'm not sure if these 2 teeth are vital because this thing is so huge. And it turned out number 2 was vital, but number 4 was not. Now again, when you look at this, this is a fused tooth. One of the things you have to read is you try to read the PDL. And you see this line here, black line, PDL, again PDL, but there's almost like 2 PDLs here. So when you see that concavity, you know that this has to be a little funky and either have a figure 8 shaped root, or it's got to have, you know, something going on. So if you look at this line right here, I don't know if you can see it, hopefully you can, you see a line here, maybe something faint here. You have to say, you know, maybe even though this is fused, this doesn't have 1 canal. And it doesn't. You can see the root canal that I did here, where I managed to clean 3 canals out of this minute 2 millimeter or less access, and look how much smaller this is compared to what happened here, and probably cost this person their tooth. So yeah, this is a great root canal, but it helped to do a great surgery and the patient died. So similarly, it doesn't help to do a great root canal and the patient lost their tooth. So that is why we're having this lecture, to really stress the importance of doing this kind of an access, okay? In this case, this is, we're looking at 12 and 13, as we call it here in the United States, and you look at this and you don't really see the roots here. I don't see them here, I don't see them here. I'm like, they disappear. Where do they go? It looks like a nuclear explosion. When you see that, it can only be one of three things. The most likely is it's a curve, and especially on a lower tooth, you would say, all right, it might curve to the lingual, and since it goes so far back and there's so much bone, you're not going to be able to see that canal. The other possibility, especially on a mandibular tooth, is that it could be a tori, or the second most common after bend is actually a split. And that's likely what you're seeing here, because this is a maxillary tooth. So you see this, and then you don't see things, and you don't know what's going on here. You know that there's something funky going on here and going on here. All right, so this is a big heads up. And it turns out that it had 3 canals. Okay. Now the interesting thing is several here. Number one, I couldn't do this without an apex locator. You cannot see where these even now you can't maybe see where these end. So you have to go by what the apex locator tells you. Unfortunately, it's 96% accurate. Okay. But the other thing it shows you is, most people will look at this and say, it's a premolar. I can do premolars. I'm good enough, and I see there's a canal here. Just because you see that coronal canal doesn't mean that you don't have this kind of anatomy downstairs. And in this case, you definitely do. You can see that we had 3 canals, and I will bet you that this tooth also has 3 canals. And that's a little bit unusual to have 2 premolars next to each other, but I've seen that probably 5 times in my career. So it does exist, okay? One way to see these images better is to manipulate the image. In this shot of a 3-rooted premolar, this is a normal radiograph that I see on Schick, okay? And I'm just showing you a regular working film because I want you to see what usually I see. You can see there's a cone cut here. I'm not trying to make this beautiful. I'm trying to show you what I will normally take. Actually, my assistant's really fantastic. Usually we don't get cone cuts, but 10% of the time I will, and that's okay as long as this is centered and this is what I'm looking at, okay? So I use Schick, and I've been using that for almost 20 years, but no matter what system you have, there are ways to manipulate that image to see what you want to see. And with Schick in particular, you can use Revealer, where you now see that a little bit more concisely and clearer. Emboss is something that a lot of people really, our residents, they never know what emboss is. They're like, I have never even heard of it. Well, take a look. Look how nicely I can read the palatal here. I can see the palatal here perfectly. I mean, it gives like a boldness to that picture, okay? You can use positive, negative is also sometimes very helpful, as is colorized. Colorized is actually more helpful when you want to see if you have gutta percha or sealer. It can give you a much more greater opacity so you can see it. But don't be afraid to manipulate the image and try to see what you see better. Just because you get this initial picture, that might not be good enough. Try to play around with it and try to see what's really going on. Okay, so we talked about getting good radiographs and anatomy, PDLs. Let's move to fiber optics, and we also discussed manipulating images just now. So fiber optics, I have a little attachment here on my unit, on my actual dental chair, which gives me like a little wand that I can touch to light up, like you're seeing here, this first molar and this second molar. It's on the same patient, as you can see. And she had 2 cracks in both of these teeth, and we ended up doing root canals. I can use this light to also look within the access cavity and look for canals. Now, some people will use just their regular fiber optic handpiece. The only problem with that is that sometimes you get air when you push on the pedal, and you don't want to internally push air, because even though it's a low risk of an air embolism, it can still occur. So if you can, try to get something like this. I don't know what this is called, but you can call Patterson Shine, whoever your usual rep is, and see what kind of fiber optic options they have so that you can better visualize both canals internally as well as cracks internally and externally. Okay? So how do we preserve tooth structure? Well, you take a look at this molar, and what you have to start looking at is Do we have a big pulp chamber here? No. So we know it's going to be harder. Here's where the mesial comes out, here's where the distal, and usually the palatal comes in somewhere between there. So you should be able to eventually say, I have to go right in the middle to get to the mesial and right in the middle to get to the distal. And you can see that's what I did here. I managed to get 4 canals, 2 mesial, palatal, distal, and look how tiny this access is. It's not even, I don't even know if it's a quarter of what the surface is of the anatomy, because I don't need to remove everything here on the distal. I don't need this here. I just have to go in the middle. If I go in the middle, eventually I find this, that little bit of pulp chamber, and that should help me, figure out where this is. Okay? So you go like this, as you can see with the arrow, you found the distal, you found the mesial, and you have to say to yourself, basically, this is what my burr needs to go, right in the middle here, like this. Go down a little bit, hopefully drop into that cavity, that pulp chamber if it exists, and you can also measure it. Don't be afraid to measure your burr and to measure this on your radiograph, and that way you know if I should go 6 millimeters, 8 millimeters, 10 millimeters, and you won't be nervous, okay? Also, don't be afraid to take a radiograph if you think you've gone in the wrong direction or too far down, okay? So always imagine what your access should be before you do it. When you have an upper molar, this is what you should imagine. Mesial here, MB2 right next to it, maybe a little bit more to the mesial usually, but not always. Palatal, the palatal will actually be here, but you will access it from here going very buccal. And here's the distal. And when you actually make the access, you can see I got all 4 canals with this kind of an access, and this is actually smaller than what I imagined. Now, don't worry and say, oh my God, I can't do that. That's crazy. This comes with a lot of practice. You can do it. It just takes a lot of, locating where canals are, and once you know where canals are, you will make smaller and smaller access. If you made this access, that would be fantastic. I can assure you that's also going to work for this tooth, okay? But the goal is to try to preserve as much of this surface area as possible, okay? So how do we do this? Number 1, we reduce the occlusion. Some people like to reduce the occlusion later on. Always reduce occlusion first. Now, I'm not talking about obviously an aesthetic situation. I'm talking about a molar that is going to require a full coverage later, a PFM or zirconium crown or what have you. So the reason you do this is because, number 1, later you don't want them hitting the tooth, because if it's acute, you're going to hurt them and they're going to have pain. Number 2, you want to get accurate measurements. And if you do all your measurements and then you knock down the tooth so that it doesn't hurt them, well, all your measurements are now off because they're shorter than what was there before. So always remember to do this first. The final thing that nobody really talks about, but I think is true, is when you make that molar flat, it really allows me to make a smaller access because I'm not as fooled by where I should go by the cusps. When you look at something in 3D, it can be a little bit trickier, okay? So after I reduce the occlusion, it depends. For a PFM, I'm going to use generally a small round diamond, a 2 or a 4, and then this is for the porcelain, and you always use a diamond, and you always use copious amounts of water, okay? If you don't use water, you're going to put micro cracks in that porcelain, and it's going to break. Once you get the porcelain and you see the metal, then you use, this is like a SS white burr that I use, or you can use any metal cutting burr, okay? And so basically this is all I use for PFMs. If you're using everything is going to be diamond, 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 and you're going to go through a lot more diamonds. Now, just for the record, I had an interesting case today. I had a lady who, on her crown, she already had a crack on the lingual aspect of tooth number 28. And so if that's the case, what you have to do is, I didn't use this. I used a really, really thinly tapered diamond, and I made a tiny, tiny, even tinier access than I usually do to stay away from that crack. Because I know if I make too big of an access with a round burr, that lingual part of the porcelain is going to fracture. And what I do is I go through 2 or 3 literally 2 or 3 thin diamond burrs because they burn very easily. But that way I make the access so much smaller than even what I do to find the canal, and I stay away from possibly breaking off a part of her. It was like an 8 or a 10 unit bridge. Okay? For a regular tooth, after I reduce it with the football, I generally use a 557. If I have to make it smaller because it's like a mandibular anterior, I might use a 558 or 558 long, something like this. Okay? and I'm really just trying to, like playing darts, hit the bullseye. This is the way most of you have been taught in school. You have a lower canine, they say, all right, you know what, let's go from the back, take a round bird, drop into that, then start opening it like this, and then go like this, and eventually you get this, okay? The problem with this is there's a tremendous amount of tooth structure here that's been destroyed. And the most important part for an anterior tooth, just so you know, for its integrity, is right here, the cingulum. If you destroy that cingulum, you're basically destroying the livelihood of this tooth, and you're risking a chance that you're not going to see it again. It's going to break. So the better thing to do is, if you can, maybe consider going straight vertical. And if you can't, because it's too sharp and not flat, or it's too aesthetic, you do that, but you try to go more towards this direction and take away from here and not from as much from the lingual, okay? Because one of the problems is you can go like this, and if this is calcified and this doesn't exist, you go like this and you can go all the way pretty much through here. And even if you don't perf all the way out here, you're going to gouge out so much tooth structure that now this tooth really is in poor shape, okay? So one of the questions we get a lot of times when I show this is, well, what about straight line access and glide path, Dr. Chick? First of all, you have to understand that the two terms are different. Glide path kind of tells you where to go. And I think everybody should look for a glide path, just like you see it naturally in life in many different forms. Here, an airplane has to know where they're going to land, so you show them, all right, this is where you need to go. You should take a hand file and always make that path before you go in with rotary instrumentation. I know there are clinicians that say, well, you can just follow the natural anatomy of the tooth. While that is true, it is not always true, and the anatomy can be so difficult that by the time you do rotary, it can already break and you're in trouble. So always use a hand file before you do any rotary instrumentation, okay? Always get a glide path. Straight line access, the way it was taught for many years was I have to see all the canals when looking down, and that is not proper straight line access, okay? You see here the palatal, MB2, MB, distal, and this is a tooth that I did in the very beginning because at first I just wanted to find those canals. I was so excited. Oh my God, I found 4 canals. Thank God, which we know 96% of the time it exists histologically in a first molar, okay? So it's always there, basically. The problem is that this is too big. You have taken away a lot of tooth structure, and in this case I did it, that really wasn't necessary. Also, I opened MB2 much bigger than is necessary. The MB2 here is almost as big as MB1, and normally MB2 should be smaller. So these are all mistakes that I made many years ago, and hopefully I don't make them anymore because I think that's the sign of somebody who is getting better. Here's an anterior tooth, and as you can see, one of the interesting things here is you got this wear. Look at all the wear that this guy has. So rather than doing what everybody's taught in school and doing your conventional access, which would be through here, maybe consider doing something like this, okay? So, yeah, because this is much more straight line and much more conservative. Here's an example. This was a lady that had 3 ceramic crowns about to be inserted, and she tripped and fell, and she had an area here, and we were concerned she broke something. And on the cone beam we could see she did break something. There are actually 2 fracture lines here, 2 fracture line here, maybe something here, an area here. I mean, this is terrible. Most people would say, all right, let's take it out. Well, the problem with that is she's paid for the crowns, you've made the crowns, they're ready to go. Is there anything that you can think of out of the box that you can do for her? Well, we looked at it, and I spoke to her dentist. I said, why don't we treat this like a lateral canal, and let's see what happens. So we did. We did the root canal, and as you can see, we got the calcium hydroxide to come out here, not just go all the way down apically, but also out here. And that's a good initial indicator that maybe there's hope yet. Completed the root canal. You could see there's still bone loss, but there's sealer that went into probably the largest fracture. And 5 months, look at already the healing that exists. I actually am going to have her back, hopefully for the next time I show this case. I have now a 2.5-year checkup on this. So this is really fantastic because here's an actual broken tooth, has fractures, that has now been in her mouth 2.5 years because we thought out of the box. Now, on a regular tooth, let's say this one right here that you see there's a radiolucency. If you're making that incisal access, this is how it looks. Tiny little space here is for cotton, or some people also use Teflon, which is like plumber's tape because it's a little easier to get out of cotton. I use both, whatever you're comfortable with. But here we go. This looks like it's more access, more has been taken away because you see the composite all the way to the top. But actually, it's been very little has been taken away because the entire lingual and the entire buccal is intact, and I went straight from the incisal. Okay. Also notice that I took this to a 45. So a mandibular incisor to a 45 is pretty significant. But if you look at average sizes for this tooth, it actually normally is a 45, believe it or not. And I know most people don't believe that. So I don't have it here, but in some presentations I show the residents, I show them 3 different studies from 3 different decades of peer-reviewed journals that show that that's the case. And here's that tooth that I showed you before with the 5 canals. This is your ideal access. It should look kind of like a trapezoid, little bit here, a lot here. But sometimes that's not feasible because it has 5 canals. And so in this case, I made it bigger than what I normally do, but that's okay. It's still good. Now, some of you will say, well, Dr. Chick, I see a lot of decay. How do you do the decay? Again, you don't have to destroy the whole tooth. In this case, I came literally sideways, and I didn't even unroof this, as you can see. There's actually a term for this. This is called a soffit, S-O-F-F-I-T-T. A soffit is the part of that chamber that was not mechanically unroofed, okay? But why do I show this case? Because look what happened. I did the root canal. I sealed this with composite, the floor and the bottom of the chamber. And I said, look, go get a restoration from your dentist and a crown. Patient never did. Came out. Year later, said, hey, what's going on? I said, well, what's going on is you got decay here, and you got this part broke down. You really need to get this done. She said, well, I need crown lengthening a little bit now. They told me, and I don't have the money right now, but hopefully I'll do it soon. Okay. Well, she didn't, but you can see I did this, and now the restoration here is larger, so much so that the decay is larger, so much so that you can't just do a restoration. She needs a root canal. Again, we try to serve as much of this tooth structure as possible. So you can do access and come from here and come from here, and look how flat it is. You know that when I'm telling you to make a straight, occlusal plane, I'm preaching what I actually do, because you can see it right here. Look how flat I made this, okay? And the point I'm showing you is, here we did everything, the patient did everything wrong, didn't get this restored. This is 3 years later, this post-op. And the reason it worked is because of the access. And I'm convinced that if I did normal conventional access, this tooth would not be here 3 years later, okay? So I told you, you really always need glide path. But straight line access, not the way we've taught it for years. This is also straight line access. But it doesn't mean coming down from here. It means coming like this. And it may be not completely straight, but almost straight, but that's good enough. And that's what you have to strive for. Okay? Radiographs are tricky. This looked like it was 3 canals. It ended up being 4. But when the patient came back, and we see that we got nice healing, the reason I show this case is because this is a bigger access than I normally make. But the reason I did it is because that's the way his anatomy was. Look how big this chamber is here. The problem is the dentist had cut too much away, and it is what it is. So sometimes there's just nothing you can do. But for this person, this is a very acceptable access, okay? So let's talk about a little bit, switch and go to how do we find some of these missed canals? Because if you make a small access like this, are you able to do it? One of the important questions you have to find, always ask yourself, besides, we have good anatomy, good radiographs, you have to say, why did this fail? And don't be afraid to look at adjacent anatomy. I already showed you a few cases where that was important. And this is going to be a great case to show you exactly that. This was a case where a dentist did a root canal right here, and he did a good job. Looks great, 1 canal. And normally this tooth, number 13 we call it in America, has 1 canal. 2 weeks later, he put a crown. Crown looks beautiful. Guess what? Now the lady has pain. You lower the occlusion, still has pain. Can't touch the tooth, killing her. Here's the interesting thing. Everybody here is looking at this. But what I want you to look at is this. When you look at that first molar, look at this anatomy. you can see something bizarre is going on here. This is going here. It looks like maybe I'm reading three roots. One here with a palatal behind it. Because I can see, look, PDL here, but here canal maybe, here canal, and then the palatal you don't see because it's behind it. And that should tell you that even though this looks like this tooth definitely has one, it's so narrow, so thin, it cannot have one. If this has three, highly unlikely this has one. And more likely this has two, possibly even three. And in this case, it had three. And once I found those two other canals, all of a sudden patient is doing great, okay? And the access I made was right here. I actually left the palatal, which is the one that he found, alone. And you say, well, how did you know which one he found? Well, you could take a cone beam and look, but I didn't even use the cone beam. What I did, I knew that if you're gonna find, let's go back here. If you're gonna find one canal, what's the canal that you're likely to find? The palatal, because it's the largest canal. And if this tooth has two, he probably missed the buccal, and three, definitely you know he missed both buccals, okay? I ended up not even touching it because I knew it was a vital tooth because he told me there was a lot of bleeding. I did just the front two. I sealed it with composite, and patient was in great shape. So one of the things I haven't talked about, but it should be obvious by now, is to do all this kind of work, you really need great magnification. I use a microscope on everyone. I don't use it for the entire procedure, but I always use it to make the access. I'll start the access without a little bit just to get it going. Then I'll use the microscope to finish it, and then I'll use it throughout the procedure, especially when I'm finished, to make sure that there's nothing in the canals. I can't tell you how many times I've etched and I saw that there's still blue after I squirted air, water, and everything. And I go back in, I'll take a paper point and clean it and squirt some more air, okay? So here's an example. Some of you might be saying, well, I see you restore a lot of your teeth. The reason I do that is I just got tired of this. I did a nice root canal on this lady, made a little bit bigger access and all, but again, she never restored it. And a year and a half to 2 years later, she came back, and you can see there was a crack in the tooth, and it was lost. And this actually happened to both of her first molars. So at the very least, I love to seal teeth so that I don't have to worry about contamination from the general dentist, from the patient's saliva, because they did a core without a rubber dam. All these things, I'm trying to make there be as little a chance that this will not succeed. And bottom line, I want to know if this root canal worked or failed because of me. How can a cone beam help, you say? Let's take a look. Here's a tooth, and I did this root canal, and this was many, many years ago, 7 years ago, I think. One of the earliest times I've been using a cone beam. I think I had it for about a year. And I did a root canal, and the root canal looked good, and everything was great. The patient did fine. And then a month later, she's telling me she's still having even cold sensitivity in the tooth. And I said, come on, that can't be. And she did. And if you have hot or cold sensitivity in a root canal, that should automatically tell you that there's got to be some kind of tissue in there that you missed. Now, in this case, you should realize, why does this person have apico, root resection? And these, by the way, were done 20 years ago. So no matter how good or bad it looks, don't be critical, don't judge. An oral surgeon did a great job for her because it's been over 20 years. The reason for this is likely they missed the canal here, and maybe didn't do a good job here. So that should tell you I probably missed the canal here. And I sure did. There was a missed MB2 right here, that little black dot. And the one thing that the cone beam helps you, I didn't need the cone beam to tell me there was a missed canal. I knew that from what she was telling me and from the fact that there were apicos everywhere. But the one thing that this cone beam did show me is where that canal is. And the reason I didn't find it is look how far this MB2 is. This MB2 is equally distant from the palatal, if not even closer, than to MB. And that can happen sometimes. Sometimes when you open MB2, it actually starts here, and then it goes eventually closer to MB. And that's why I didn't find it. Now that I knew where it was, I had the confidence in finding it. I was able to find it. Then I went on vacation because once in a while Dr. Chick has a good life and he has to take a break. And my partner at the time, Dr. Shivian, was kind enough to obturate it. And interestingly enough, he used to use Resilon, which I don't even think is on the market anymore, but which is why this is more opaque than these canals. But you can see, bottom line, we found that fourth canal. It was obturated. It looks great, and she did great. One other thing I'll mention is, again, when we look at things, you say, well, this doesn't look perfect. This is not perfect, but it is short, meaning the crown is still closed, but it's not perfect. And the reason for this is it's very difficult to do a crown margin on tooth number 2, especially the distal. So, one of the things we love to do is judge. I try not to judge, and I think the least you judge, the better you will be as a clinician, okay? So, but speaking of judging, you have to judge the difficulty of things. And the way you do that is you take good radiographs, you evaluate the adjacent teeth, like I told you, something that I think most people don't discuss. And it's important. A long tooth is harder than a short tooth. A curved tooth is harder than a straight tooth. A coronal bend is worse than an apical. You have to look, can they open enough? Sometimes they can't. Do they have a lot of anxiety? Maybe they need sedation, and this is not the person for you. And restorability is the ultimate. If you can't fix it, what's the point of doing the root canal, all right? So in summary, good radiographs are imperative. I always show this slide in probably every single lecture I ever do, because this really tells you why you cannot trust radiographs. This is a tooth that we extracted, did a root canal, and we say, how does it look? And everyone says, well, it looks pretty good. I mean, forget the access here for a minute. Just look at the obturation. It looks great, right? Not so much, okay? Remember that we do everything in 3D, and we look at things in 3D. And so what looks good may be actually horrible, because this is maybe 20%. So if this is 20% clean, it's not 80% dirty. This is 100% dirty, okay? So use magnification. Use fiber optics like I do here to light this up to see. You can see the 5 canals, 1, 2, 3, and there was a double distal here, 1, 2, 3. Okay, loops, if that's the best you can do, fine, but you have to have at least 3.5 times expanded vision. Imagine your access cavity. So here we have a zirconia crown, and remember I told you, imagine, you could imagine where to go. You could say, this is where I need to go from the mesial, not from here, and remove all this, from here. This is where I have to go to the distal. There's your X. Start to connect the dots, and this is what you're going to remove. And from this, you can do this, 4 canals, and look at the access. Now, again, this takes many years of practice. Don't just think you can, but what I'm trying to show you is this is possible. I did this through this. That's right, okay? And again, in this case, I can't flatten it because it has a zirconia crown, but normally I would love to flatten it. It would make it even easier. But what I do is I know this is in the middle. I go pretty much in the middle, but slightly to the mesial, and then I start looking and see what did I find. And based on what I find internally, I can much more easily then realize what direction I have to go, okay? So even though this is not ideal access, and I'm not proud of this anymore, I was very proud of this, 15 years ago, or 12 years ago when I did it, it's still acceptable, okay? But this is more along the lines of what we want to do. I generally see this. And this is what my referrers see when they take it off. I didn't even clean off the cement. I just said, let's take this off. Let's take a picture. I want people to see, if you're getting a tooth back from me, what it's going to look like. And this is the access that you will see, okay? And it's important because on a lady like this, she has a rest seat here for her partial. And it's not so easy to make a new crown that you can retrofit to the partial, and not everyone has the money for that. So this was a lady who was 75 years old. I said, you know what, I'll do the root canal, and then we can send her to the dentist. They can just put an amalgam in here, and it'll save her tooth for several years, and she'll get some mileage out of it. And that's really worthwhile, in my opinion, okay? So a lot of people will always ask me, Dr. Chick, what do you use? So here we go. I use a football diamond, especially for reducing the access, 557, sometimes 558, sometimes long if it's in an anterior tooth, a round diamond burr, usually 2, something small, SS White, metal cutting burrs, it's the 1 or the 2 burrs that they have, straight diamond burr, and sometimes I'll use a straight in lieu of round burr. It depends. Like I told you today, I had to. Have to have great magnification, so you need a microscope. I like ultrasonics because you can see what you're doing with ultrasonics better, but if you don't have the luxury, you can also do it with a slow speed and a round burr, but the problem is it's very hard to see sometimes because the slow speed gets in your way. Even if you use the longer, extended round burrs, it's still hard. Illumination is key. If you don't see, forget it. You're going in blind. Irrigation, Bleach nowadays in the United States, if you look at it, a lot of times it's 8.25%. I don't know why it keeps going up. It used to be 5.25%, then it was 6.25%, now it's 8.25%. So basically, I do somewhere between 4 and 5% because we generally dilute it almost 50-50. And I also use EDTA because you want to get rid of the smear layer. And I use this from Roydent. The nice thing about this is, you know, it has a surfactant. It's great at getting rid of that smear layer, and you can also get in these little small capsules. Okay, I actually just put it in a syringe, but I know a lot of people who do this because they like it. It's convenient. You don't need a lot of EDTA. Too much EDTA can actually weaken a tooth if you just soak it and soak it and soak it. So you really only want this for a few minutes. What I generally do is after I use a hypochlorite, I'll rinse it with EDTA. I'll put my cones in. Then I'll take the master cone radiograph, and that way the EDTA has been in there for a maximum 5 minutes. Then I rinse it out with the bleach one last time, use paper points or Endovac, and then I can obturate. I used to love Term. I still do, actually. But unfortunately, they took it off the market. It wasn't selling. I guess I'm the only person who was buying the stuff. So if you're wondering, hey, what did he use? I love that material. Well, this is what I used to use. And even though it's been off the market for 4 months, I think I still have my very last bit, and probably in about another month, it will definitely be gone. So I generally will actually use composite. You know, IRM is not good. There have been studies that show that it leaks, a lot of studies. So Cavit is fine. I don't like Cavit because it sometimes dries out. The consistency isn't great. I can use it, and for the holes I make, I can use pretty much anything. But I'm just going to use regular composite. And you know what? If it's a little more expensive, fine. I'll charge the patient a little more if I have to. But I do not want this thing coming out and my whole root canal getting contaminated in between appointments. I can tell you in a year, I have less than 5 patients where the entire restoration has come out. And in fact, I have probably only 5% of patients where it's been worn down, because I really do a full cure to make sure I have that in as well as possible. Okay? One of the things you can look for locating canals, I didn't mention, but and this is also from Roydent. By the way, I use products from everyone, from Tulsa, from Kerr, from Roydent. If I think it's good, I will let you know that. They have to die for it. It can stain for decay. It can also stain for tissue. And it's really fantastic because if you're looking for that MB2, sometimes you can squirt that in, rinse it out, and you can see all of a sudden there's a spot, and you go in there and you realize that's where the canal is. Okay? You can use regular hand files or like this NiTi, which has memory. I generally use K files. My favorite file, though, is actually the C file that Roydent has. It's a little bit of a stiffer file. I like using it in sizes 6, 8, 10. I don't know, a lot of you guys might not use a 6 file, but as an endodontist, you have to. Okay? And if you want more information, you can go to google.com. A long time ago, I did some, videos for Roydent. So you can go there, just go to google.com, literally just type in Roydent Dr. Chick, and you will see there will be some clinical education videos, even obturation, instrumentation, and hopefully that helps you. One other cool thing that if you look up on Google, Castillo training model, Castillo Endo training model, you'll see it might be from VDW, which is a German company, but in the U.S., I know Roydent sells this, and you can actually have a block like this where it has several teeth, where their access, you can try instrumentation. Not only that, but you can also have some canals already obturated where you can try to get that out. You can try your measurement, and there's even some that will have MB2 there, but it hasn't been accessed, so you can try to practice looking for MB2, which I think is really, really going to be helpful. Okay, let me just see here. We're almost at the very end, and we're going to go to questions. I think I have like 3 slides remaining. The advantages to a small access, it's really just this, preservation of tooth structure. But this is everything in endodontics. If the tooth breaks, we go home. And so we want to do everything we can, to do a great root canal, but also preserve that tooth structure. Will it make it harder? Sure. It's harder to see. It's harder to irrigate. You might have to take more PAs. There are times I have to take 2 radiographs because I can't fit all 4 cones in my access. So I take MB and MB2 and then distal and palatal, or MB and DB and then MB2 and palatal. But 1 extra radiograph that's digital in today's day and age is not a big deal. you're more likely to miss a canal, but again, with experience, you'll get better. Less straight line, so it's harder. But at the end of the day, you have to remember this. Preservation of tooth structure, in my opinion, should always trump the root canal. You can do a great root canal, but if you broke the tooth, so what, okay? And we see this in medicine, right? You want efficacy. Everybody wants the drug to work. But if it kills the patient, what good is it? Safety trumps efficacy. Tooth structure should trump root canal therapy, okay? And despite all this, you can still find 5 canals, you can irrigate, you can see fractures, do all these things, and hopefully achieve greater endodontic success. I hope this was very fruitful for you. I'm about to take some questions, and I'm going to try and go through as many as I can to hopefully help you, okay? All right, first question. Why are so many endos being done on teeth with either minimal or no restorations? Very few of the teeth shown have caries. Well, the reason for that is it's not just caries. Occlusal trauma is a big deal. I have probably 1 tooth a month that has a totally virgin tooth where, the tooth failed just because of grinding, believe it or not, or because the occlusion was not right, because a restoration was done above it, and now that tooth was being slammed, okay? I see a lot of times where an amalgam of 15, 20 years gets wedged and cracked, and therefore, therefore that also causes cracks that eventually propagate to the tooth, to the nerve, and then you end up doing a root canal. Glass ionomer for access. Glass ionomer is fantastic. If you want to use it, that's also great. Chlorhexidine in necrotic infective case. And it says nice presentation. Thank you. I appreciate you saying that. Chlorhexidine is great. I use that sometimes as an intracanal medicament. You just have to be careful with chlorhexidine, EDTA, bleach. All these things form precipitates. So when you're rinsing, you have to really do a great job and be careful because you don't want to mix as much. You really want to clean it out as well as you can because sometimes that can cause a precipitate that can cause there to be bacteria. Okay. Let me see what else we have here, because we're getting a lot of questions now coming in from you, which is fantastic. Doc, I have 2 questions. Although a smaller access is exciting, does it pose risk of leading unsupported tooth? Again, the one time that I'm worried about making too small an access is when I'm going to eventually do internal bleaching. Then I will open it more. But otherwise, no. If anything, you're going to have, much better tooth structure. Okay. Let's see here. Let's take a look. And I'm sorry, I'm getting a lot of questions here, so I'm doing my best to try to read all of them for you. Somebody was asking if we can get access to some of these photos. I actually don't know about that, but if I can, I'll be happy to give you some. You can always email me. My office email, which also is now become my personal email, is njrootcanals@gmail.com, NJ like New Jersey. So if there's something here that you really have a question that I'm not able to answer, let me know. Somebody asked how often I utilize the cone beam. The cone beam, I generally use it for 10% of my patients. At the end of the day, this is actually a very interesting topic. We can just talk about cone beam for 10 hours. The question is, do you want to always know precisely how many canals are there before you do it? It's kind of like this. Do I want a full scan of my body to see if I have any tumors? Ideally, a lot of us would say yes, but practically, there's some negatives to that. There are people that, just like prostate cancer, they die before the cancer kills them. Similarly, at the end of the day, if you miss a canal, it's not a guarantee that you're going to fail. If the tooth isn't infected, it can work for 100 years. It's like the Leaning Tower of Pisa. It doesn't look good, but it might be 400 years before you have to remodel it, okay? Practically, we want to do everything perfect. We're neurotic. But, also you have to say, you don't want to expose people to all this radiation, even though it's low. And my machine, it's 18 to 25 millisieverts, which a CAT scan will be 5 to 12,000. You still don't want to do that. Someone was asking about internal bleaching. What do you do? I just use sodium perborate generally, but you have to make sure that you seal the chamber with either glass ionomer or composite, and make sure that it's sealed very well, so you don't get any kind of resorption. By the way, thank you for everyone. I got a lot of people here saying that it was a really great presentation, so I appreciate all of you guys that said that. Someone asked about the single cone obturation technique. That's fine. You can use single cone. I don't think you can use single file, and that's something to be really stressed. Everybody's tooth is different, so you have to treat that tooth based on what you see. And I can get tooth number 3 and number 2 and number 18 all day and have them be completely different. When you're finished, once you've shaped it, you want the biggest cone that you can to fit that in without using too big a cone where you might be binding coronally or mid-root and not really getting tug back. But this again goes into obturation, which unfortunately was not the goal of this presentation. Okay, let me just take a look here. Thank you, Joseph, for saying it's impressive work. I appreciate it. I appreciate all of you guys taking the time, because I know we really have people from all across the world, literally. What's your technique for letting sealer out through the apex? So let me just say there are two schools of thought. Some people like sealer out the end because if you go to BU where I trained, that means that you were patent and you cleaned everything. Some people will say, well, but you're going to cause inflammation. I'm going to tell you I prefer to see it out, not because I trained at BU, but because, if you finish something short and it's necrotic, you're leaving bacteria there and it will likely fail. If you go long, even if you go long and you're not perfect, and I don't mean long like 3 millimeters long, but hair long, where you see a puff, I find that rarely does that give somebody any significant discomfort. I mean, yeah, for a day or two, but not long term. And I need to know that this was cleaned all the way to the end. Okay, so in my opinion, it's better to have a puff. What's the best way to de-roof the pulp chamber? So generally, I'll go in. Again, like I said, I'll make it flat. Then I'll go in with the 557, and I will just make the access, everything almost with the 557 or a thin diamond if I need to. I think initially when you're learning, it's good to maybe consider going in with a round burr, like a small one, a 2, a 1, a 2, a 4. You actually want to go a little bigger than what you would think, because if you go too small, you can gouge it. If you go a little bigger, you will remove more access, but you're less likely to gouge the floor and perf. So you can go with a round burr and then eventually use even a non-end cutting burr, which is like a 557 where the tip doesn't cut. And that's, I know, going back from 20 years ago when I was in dental school, that was a 856 burr. But they have all kinds of different names. But you basically, or an Endo Z burr, which is a non-end cutting burr, and you can use that. What do you get the sealer into the lateral canal so well? Okay, again, I really clean teeth well, okay? You have to clean it well. If you clean it well, you will get it to go. And by the way, when you make small accesses like I do, there's really nowhere else for this to go except for either apical or through the lateral canals. So when I use EDTA and I use Endovac, I don't use Endovac on everybody. It would be good, but it's difficult and it's hard to get it in with some of the holes that I make, though you can, because if you open it to a 35, which usually I do, you can get the micro cannula in there. You'll be able to get it. As far as the sealer I use 2Seal, which is from Roydent, just because I really like the opacity, the flow, and bottom line though, you have to clean it out well, and you always should use a resin sealer. Okay. Let me just see, maybe we'll do one last question. How did you irrigate the mid-root fracture and with what? Again, I just use hypochlorite and EDTA. Remember, this is not like a huge crack, like the tooth is broken, but this is a little microscopic crack. It has to be greater than 0.15 of a millimeter to be shown on the cone beam. Otherwise, it won't show up. So I just treat it like a normal tooth. Last question, how can we ensure that post-endo patients are pain-free? Well, by the way, someone said, just got another one, the Roth cement. You can use anything, you just don't want to use a eugenol. You can use a eugenol cement, you don't want a calcium hydroxide cement. So Seal Apex is not great. You can use Roth, I believe that's eugenol. I don't know every cement, but like I said, I use 2Seal, which I'm very happy with. Going back to the post-operative pain, I think the more you do with With rotary, more of that stuff is going to go coronal versus apical. The better you clean things, the better. And if you find everything, I mean, if you find 4 canals and there's 5, you're going to have postoperative pain. So I do necrotic teeth in 2 visits. I always put calcium hydroxide. And I'm going to be honest, when I started this, I've been here already, I think over 11 years. I had a lot more people. Almost every day I'd have someone in postoperative pain. And now I have generally 1 a week, and I see a lot of people. I'm talking about 1 where it's of any significance. All right, so again, thank you all. Really appreciate you listening to my lecture. I hope it was enjoyable, and I hope you all have a good evening. And if you need me for anything further, feel free to email me at njrootcanals with an S, plural, at gmail.com. And please go to those pages on Roydent if you want to see maybe some more material. I think it'll be helpful. Thank you again, and to everybody, have a good night.